So I'm one of the BMT attendings, but I've also been a general oncologist. And one of the things that I've noticed about my specialty is that a lot of the terminology seems scary to people who are outside the specialty, but it really shouldn't be, because oncologists are internists who treat malignant conditions, and most of what we do touches on a variety of areas of internal medicine. So there's a lot of shared ground, and typically, as an internist, you're going to be taking care of oncology patients, because about 1/3 to 1/2 of people, depending on how much cardiovascular disease they have, will have an oncologic condition or die from one. So this is going to be common in the world of medical practice. So it's helpful to understand the terminology and understand what's going on with the patients and how do we treat some of the complications of oncologic treatments. So I'll start off with why we give chemotherapy, what are the typical situations, and how we decide which patients are good candidates for getting chemotherapy. Then I'll talk about some of the different access devices we use to give chemotherapy, what they're called, their basic anatomic functioning, and how long they should stay in, and what are some of the problems with having them in. And then we'll spend most of the talk on toxicities of treatment. What are common toxicities like nausea, tumor lysis syndrome, and how do we manage them? And if there's time at the end, we'll go look at specific drugs and some individual things that every internist should know about them. So I frame this with a case. This is a patient I took care of. He was a 75-year-old gentleman who had a large mesenteric mass that appeared to be a lymphoma, and on biopsy it was confirmed to be so. Diffuse large B-cell lymphoma, high proliferative index, a lot of cell turnover, but a treatable situation even in a 75-year-old. So shortly after he was diagnosed, he wasn't sure if he wanted to get chemotherapy. He was looking at alternative therapies, but he tried them, they didn't work, and he showed up in the ER shortly afterwards with pain and hypercalcemia. So, what do you do for someone like this? Well, for a 75-year-old, at the time he presented, we said, you're a candidate for our CHOP. And so we'll frame some of the talk around the supportive care for him. So chemotherapy is a systemic approach to cancer treatment. So for most of the 20th century and the early part of the 21st century, when we talk about chemotherapy, we've talked about intravenous drugs that target rapidly growing cells. And they target some sort of cellular process like the mitotic spindle or DNA replication to target the fast-growing cells. More recently, we have a proliferation of what we call targeted therapies. These are drugs that target individual growth pathways and are thought to be more specific for cancer cells, but I would argue that they're similar to the other chemotherapy in the fact that they have a lot of off-target effects. So they might be targeted towards a certain metabolic pathway to target cancer cells, but they still have significant systemic effects. And these particular targeted drugs typically fall into the class of inhibitors of enzymes or monoclonal antibodies like rituximab or bevacizumab. So what are situations where we use chemotherapy? Well, one example is the patient I initially presented where you have an aggressive lymphoma or leukemia and your goal is curative intent. If you can eliminate enough of the disease, the immune system can probably take over and scoop away the rest of the remnants. So some cancers, we can cure them with chemotherapy alone. Another example is testicular cancer. Most of those patients can be cured with just chemo. Sometimes we use chemo for palliation only. We know that we're not going to be able to save a person's life, but we can reduce their symptom burden, we can prolong their survival, sometimes for years. And a good example of this is indolent lymphoma. Some solid tumors like ovarian and breast cancer, we can keep the patients alive, working and functioning for years. Sometimes we use chemotherapy as part of a stem cell transplant or as part of multimodality therapy. So head and neck cancer, often patients get some combination of surgery radiation and chemotherapy. And the chemo might serve as a radiosensitizer. Some of the DNA damage from chemotherapy makes those cells more susceptible to killed by the radiation. Sometimes we use the chemotherapy after surgery as mop-up. And, for example, in colon cancer or breast cancer, chemotherapy after resection is shown to improve outcomes. So in a relatively healthy patient, they might be a candidate for that to give them a better chance at a cure rate after a local therapy like radiation or surgery. I mentioned stem cell transplant, and this is probably the most intense application of chemotherapy and one that's the most specific. And I do a lot of this, and we give large doses of chemotherapy which decrease disease burden and immunosuppress patients so that they can receive the donor stem cells and have engraftment. And to some extent, we're buying time to keep the leukemia beat down so that those donor stem cells can get in there and establish an immunotherapy effect. So those are the situations in which we typically give chemotherapy. And how do we choose which patients should get it? So we look at the disease stage. So if the patient has a disease stage that is appropriate for chemotherapy treatment, where there's clinical data that says it's effective, we look at them as a candidate. For example, a patient with very early stage head and neck cancer that might be cured with radiation alone, I probably would not suggest adjuvant chemotherapy. Perhaps the bigger issue is the patient's performance status. Is the patient going to tolerate treatment well? Is the risk of toxicity excessively high? So not so much age, but their performance status. And their performance status is a general measure of their well-being, how well they function. So someone who's a marathon runner has a very good performance status. And we use 3 different scales for assessing performance status. One is called the Karnofsky score. That was the first one. It goes from 0 to 100, where 100 is good. The Lansky score is the equivalent of the Karnofsky, but it's used in pediatrics. So the Karnofsky score talks about people being able to work, whereas the Lansky score talks about people being able to play. And the ECOG is probably the most commonly used scale, and it's the newest one, and it's the most popular, I would say, because it has the simplest system. It only has 5 levels. It goes from 0 to 5. But in this case, higher number is worse. 5 is dead. 0 is asymptomatic. Performance status matters because it tells you how your patient is doing. It's not a number that's assigned at the start and doesn't change. It's assigned to whatever place and time the patient is. So if the patient looks very good at the start of therapy, their performance status might be 0 or 1. But if they get hospitalized with neutropenic fever and they have to go on the ventilator, their performance status would be a 4. So here's the Karnofsky scale. As I said, 100 is great shape, 0 is dead. And generally, patients who are 70 to 100 on this scale are candidates for some type of chemotherapy. Would you give an intense regimen such as a bone marrow transplant conditioning regimen to someone who's a 70% on the Karnofsky? Probably not. But you might be able to give some type of less intense chemotherapy to a patient with that performance status. And the ECOG is analogous, where 0, 1, and 2 are usually the performance statuses that we consider a patient strong enough to get chemotherapy. The dividing line that is pretty practical and easy to remember is, do you spend more than half of your daytime hours resting in bed? If you spend more than half your daytime hours resting in bed, chances are your functional status is not commensurate with receiving chemo. Now, there are some exceptions. Patients who have a tumor that is causing the functional deficit and that will quickly be eliminated with chemotherapy, such as a testicular cancer or a lymphoma, that you might say someone's a performance status 3 or 4, but with chemo, they might spring back to life for you. But a lung cancer patient or a pancreatic cancer patient, chances are that you're not going to change their performance status dramatically from a 3 or a 4 up into being a chemo candidate. So how do we administer these drugs? Well, some of the drugs can be administered by a peripheral IV, but a lot of them have a property called vesicant status. So a vesicant is a drug that causes direct tissue damage. So it comes into contact with your skin, kills the cells. So you don't want it to leak out of a peripheral IV into the soft tissues, because that's a catastrophic outcome sometimes. So long-term venous access reduces the chance of having a leakage, and it also makes it a little easier for the patient. They don't have a lot of their veins damaged with frequent sticks. You also can give some drugs that can only be given by a central access that way. Example is total parenteral nutrition. But you have to do a procedure to put one of these lines in, and they come with risks. They can get infected, and they can increase the risk for thrombosis. Your risk for thrombosis and infection depends upon how long the line stays in, the quality of the nursing care in terms of line changes and dressing changes, and how well the patient is compliant with their flushes and their dressing changes and their line care. So one type of device is called a Hickman catheter. You might hear this term used. There's also Broviac, and there's a variety of different names. Basically, they're tunneled access catheters. The Hickman is probably the most common brand name in use. It's named after a pediatric nephrologist who initially developed it for pediatric patients who were getting dialysis. So it's placed under fluoroscopic guidance. It goes through a subcutaneous tunnel. This subcutaneous tunnel, before the line goes into the vein, causes scarring, and that's what helps protect against infection risk. Typically, they have more than one lumen or tunnel as part of the catheter, and they can usually be used for 3 to 4 months. So it's a big convenience for the patient. A port is another one that you probably have been accustomed to hearing about. A port is similar to a tunneled catheter in that it goes into a big vein and does have a subcutaneous tract, but it doesn't simply exit the skin and give you immediate access. You have a reservoir that's subcutaneous that can be accessed with a special needle. And this special needle is typically called a Huber needle. And the Huber needle is usually a needle that has a 90-degree kink in it. So it sticks in and then it goes off to the side, which is usually the most reasonable way to shape the tubing for the nurses to use. It goes into a reservoir, and then this line leads to the vein, and they have to be accessed by specially trained personnel. The plus about them is that the infection risk is lowest because they're not exposed. It's basically hidden. And they can be present for years, but they typically have to be flushed every 4 to 6 weeks. So it's not something that can just be left and neglected. A PICC line is another one that we use for chemotherapy. It's probably the easiest to put in, but it also is troublesome in some ways. They are the longest catheters, and in my opinion, probably have the highest risk for clotting because of the length. They can be placed at the bedside, however. You don't require a physician. The IV team can place these lines, and they are essential access. I typically think they should be used for short duration access needs of weeks to a couple months, but some of them are FDA approved up to 12 months, but I would not recommend having a PICC line present for 12 months. So this gentleman came into the hospital, and we wanted to get R-CHOP treated quickly. And one of the drugs in R-CHOP is a vesicant, and the H in R-CHOP is the vesicant. This is a hard one. What does the H stand for? It's the least intuitive on here. Acidoxorubicin, exactly. So hydrodonomycin. I didn't name it, But the C is cyclophosphamide, that's easy. The O is oncovin, which is the original trade name for vincristine, and the P is prednisone. And the H is the hydrodonomycin. Of course, it comes up with a nice acronym, but this is the doxorubicin. Both the doxorubicin and the vincristine are vesicants, and we wanted to use a central access. So we put a PICC line in him, because he was going to be in the hospital and get his first few cycles over a couple months. So we weren't anticipating the need for a long-term access. So that's why we went with a PICC line. It was quick, and it got the job done. And he started his chemo shortly after he was admitted. So let's talk about the toxicities, because this is a lot of what you deal with in oncology. So you may see in published articles we grade the toxicities from grade 1 up to grade 5. Usually they talk the most about the grade 3 and grade 4 toxicities. Those are the ones that put the patient at risk for hospitalization and are the most likely ones to convince the patient to stop therapy or want to cut their therapy short. So they range from mild to severe, and different toxicities have different thresholds. For example, tumor lysis syndrome starts at grade 3. Alopecia only goes up to grade 2. You don't hospitalize anyone for alopecia. So nausea is a frequent toxicity, and it's frequent enough that we administer most patients receiving chemotherapy some type of prophylaxis. And the different molecule pathways that can trigger nausea include the serotonergic system, the dopaminergic system, neurokinin 1, and the cholinergic system. And I've put in parentheses some of the different drugs that we use to target these pathways. So we have the serotonergic antagonists, or the 5-HT3 blockers. And this class of drugs came in the market in the 1990s and really revolutionized the field of chemotherapy, because it made chemotherapy much more tolerable for a wide range of patients. Previously, it was hard to have complete control of nausea for a lot of regimens that might have drugs that were based on platinum molecules, for example. And now most patients can get breast cancer or lung cancer chemotherapy and have minimal nausea at the highest with good use of prophylaxis. Another mainstay are the phenothiazines, such as promethazine and prochlorperazine. This is Phenergan, that's compazine. Even Zyprexa or olanzapine can have a role in helping refractory nausea. For chemos that are very nausea-inducing, we'll go after the substance P pathway. And for some patients, it might be helpful to give them some anticholinergic activity through either antihistamines or a scopolamine patch. A couple other things to think about. What's the setting of the nausea? If it's anticipatory, in other words, the patient has not received any treatment, but prior memories of treatment or fear is causing nausea, lorazepam might be helpful. In acute nausea, we think that ondansetron works better in that setting, and for delayed nausea, either dexamethasone or aprepitant in severe cases may be good go-to agents. Although I would say in my experience, the 5-HT3 antagonists are excellent nausea drugs, even in non-chemotherapy settings. Risk factors for having chemotherapy induce nausea. The highest risk factor is probably the chemo regimen being used. The drug and its potential to induce nausea is the major factor. But there are some patient-specific factors. So younger patients, female gender, patients who don't drink alcohol, patients with a history of anxiety, they're more prone to chemo-induced nausea and vomiting. I like to joke that at the VA, all these factors are nicely aligned so that the patient's nausea is well prophylaxed against just by the fact that they're at the VA. Regimens that you might be thinking this patient has a high risk of nausea because of a high emetogenicity, cisplatin in higher doses, high doses of Cytoxan or ifosfamide, and these agents aren't used very much anymore, but they're still used occasionally for CNS tumors, carmustine and dacarbazine. So these are the agents that would make you stop and think, is this patient on a good prophylaxis regimen? And by good prophylaxis regimen, I mean 3 antiemetic agents for prophylaxis. Most patients fall into this category, moderately emetogenic, and a steroid and ondansetron or Zofran is adequate prophylaxis. So for most patients getting chemo, you probably can't go wrong if you put them on dexamethasone and ondansetron. If patients get admitted to the hospital under your care for nausea and vomiting after chemo, to be resourceful, you can add a new class of agent that the patient hasn't been treated with. You can use scheduled dosing instead of as-needed dosing, and you can, of course, use more than one agent at a time, trying to balance their different toxicities, such as QT prolongation or potential for causing diarrhea. So this gentleman getting R-CHOP, which I consider to be a moderately metagenic regimen, and of course I wouldn't expect residents to know that stuff. I gave him ondansetron and dexamethasone, the pretty standard prophylaxis. So mucositis is a side effect of chemo that we see a lot in the BMT setting, probably not so much in the general oncology population. Mucositis happens not because we kill the cells in the mucosa through the chemotherapy effect, but because the chemo causes free radical damage, and this releases inflammatory cytokines. And so the ulcers come later. So typically, patients who have mucositis will have pain often before the ulcers form. And so I often tell people it hurts worse than it looks. Someone might have a very mild erythema in their mouth but have severe pain. They're not faking it. Their ulcers will form later. Ice chips, oral rinses with saline or peroxide, lidocaine mouthwashes, that's what we would call magic mouthwash. Here at U of L, I learned this terminology when I first came here. It's called Mary's Magic Mouthwash. So Mary's Magic, if someone has mucositis, that's what you go to, probably as your first line. For people who have severe mucositis, they may have to stop eating and they might not be able to tolerate oral medication. So TPN and a PCA pump for them. Some patients, you can expect mucositis. Head and neck cancer with combined chemoradiation, they surely will not be able to tolerate enteral feeding during their chemorads, and I always put a feeding tube in. It's usually short term. That's for chemoradiation in head and neck. And mucositis does not always happen at the front end. And for those patients, we have Tux pads, which are witch hazel, and in Seattle we called it Boston butt cream. I'm not sure what the etiology is. I don't know if that's a reference to personality types from New England or if they originated it there. Here at U of L, we have Wandas. So Mary's Magic, Mary for the mouth, Wanda for the wazoo. So Marys and Wandas. So we have Wandas for rectal and anal mucositis. Diarrhea can happen after chemotherapy. It can be from mucositis. In the case of 5FU, it can be because of the death of crypt cells. It can be particularly bad in patients who have a DPD polymorphism. Irinotecan is another chemotherapy drug which is notorious for causing diarrhea, and that can be managed with either atropine or loperamide. In general, for patients who have diarrhea after chemotherapy, it can be multifactorial. It could be toxicity to the cells of the intestines. It could be due to changes in the bacterial colonization. It could even be due to nosocomial exposure. And I usually tell people, don't drink too much coffee. Get off magnesium if you're taking it already. Hydrate the patient. Use loperamide. And for severe diarrhea, octreotide may be effective. Hypersensitivity reactions are another set that occur fairly frequently in oncology. Some of the agents we administer or the chemicals that go along with them to ensure solubility are immunogenic. Symptoms can run the gamut. It can range from rash to an anaphylactic reaction. Usually this happens shortly after the infusion. So if someone gets their chemotherapy and comes in a couple days later with some sort of hypersensitivity reaction, it's probably not the chemotherapy. In general, I would say it should be within 6 to 12 hours of the chemo to classify as an infusion reaction. a delayed example is cytarabine, which we'll mention briefly. So taxane drugs can do this. That's Taxol, which is paclitaxel, and docetaxel. And the reason that happens is to get these drugs into solution, you have to administer them with a detergent. And it's probably the detergent that is causing the infusion reactions. So I treat patients by stopping the infusion. I let the reaction clear up. I assess the patient. They may need IV fluids. If they're in anaphylaxis, they should get epinephrine. If they have airway symptoms, you could consider a nebulizer treatment. And then I think about, how am I going to get this infusion going again? How do I finish the patient's therapy? So you can augment their prophylaxis or give them medication. So most chemotherapies are given with some form of reaction prevention. Often the dexamethasone that's in the antiemetic prophylaxis helps with reducing the rate of infusion reactions. But you could add medications. So you could add diphenhydramine if they haven't received an H1 blocker. You could add famotidine or ranitidine if they haven't gotten an H2 blocker. You could increase their corticosteroid, or you could add one if it hasn't already been used. When you restart their infusion, it restarts at a lower rate and you slowly ramp it up. And if you're prescribing their chemotherapy, you would be well advised to think about adjusting the premedication before the next cycle of treatment. So a little more detail on the drugs that do this. The platinum agents, taxanes, because they use the detergent, and usually the specific term is a cremophore. Taxanes come from the yew trees, YEW, and they're derived from the bark of those trees, and they're not water soluble, so they have to go into detergent to get them into a human. Cytarabine is a primarily leukemia and lymphoma chemo drug where you can see a delayed reaction. And sometimes it causes a rash a couple days after the infusion is given, and sometimes it causes what's called cytarabine syndrome, which is rash and fevers 6 to 12 hours after infusion. Other frequent offenders include monoclonal antibodies, such as rituximab. Some of these antibodies are humanized, some of them are chimeric. I don't think you can look at the name of the antibody, for example, and say, oh, rituximab is chimeric. Therefore, you're going to have a higher rate of infusion reaction. It turns out that there are humanized antibodies in the same class of rituximab which have higher infusion reaction rates. I can't tell you why, but they do. Monoclonal antibodies, though, you have to be on the lookout for infusion reactions. And I should mention that blood products, while they're not chemotherapy, often cause hypersensitivity reactions, and blood product reactions can be managed in the same way that you'd manage hypersensitivity reactions. So this is a little bit repetitive, so I'll skip through this one. And we discussed some of the basic principles of treatment, but this is in more detail. So this gentleman with DLBCL who got a PICC line and got ondansetron and dexamethasone received some pre-medication before his rituximab and his chemo. He got acetaminophen, he got diphenhydramine, and he got hydrocortisone. And that worked fairly well for preventing infusion reactions, but he actually developed a lot of severe akathisia from the Benadryl. And so he requested something to deal with that. And they gave him lorazepam, and they gave him too much. So he went home and he took 6 lorazepam, and he had a fall. So that's the lesson in, the chemo didn't cause it directly, but you have to be careful when you're taking care of the supportive care of older patients. Agents such as diphenhydramine for preventing infusion reactions, I don't see any reason why you couldn't use cetirizine or loratadine in its place. So tumor lysis syndrome is one you may encounter. That happens when a rapidly growing tumor has a lot of growing and dying cells that are releasing their contents into circulation, or you give chemotherapy and you achieve a high enough response rate and a rapid enough one that most of the tumor cells die, but they all die at once. Well, what's in these tumor cells? They have a lot of DNA, and they have a lot of proteins. And when they die, they release all of their intracellular potassium and nucleotide components into circulation. And so we see elevated uric acid, elevated potassium, elevated phosphorus, but you'll see decreased calcium because the phosphorus binds the calcium. So there's also risk for hypocalcemia. So it's more common to see it after chemotherapy, but it can be spontaneous. So patients who have highly aggressive B-cell lymphomas or Burkitt lymphoma, they often will present with tumor lysis syndrome. So aggressive non-Hodgkin lymphoma histopathologies are frequent offenders on this list. And in acute leukemia, all the patients who get an acute leukemia induction, they get tumor lysis prophylaxis as well, because even if they don't have a high blast percentage in the peripheral blood, their bone marrow may be full of blasts, and all those blasts, if they die after the chemo is given, will release their contents, so they might have a high tumor burden as well. So allopurinol and hydration for everybody who gets leukemia induction. And finally, some solid tumors. For example, if you're treating a testicular cancer patient, you may consider tumor lysis prophylaxis because a lot of those germ cells will die when the chemo starts. So for prophylaxis, you want to give them adequate IV fluid. 125 cc's an hour is not adequate. You should think about their dosing based upon their surface area. So 2 to 3 liters per meter squared body area per day. So we're talking 250, 300 cc's an hour in some patients. It depends on their overall health and other factors. Don't use Ringer's lactate because that has potassium in it, and you don't want to throw extra potassium into a situation where you're releasing potassium into the blood potentially. Allopurinol is used. It's very standard. Some physicians will recommend urinary alkalinization. This is controversial. There are some practitioners who believe that urinary alkalinization does not help with the excretion of some of the compounds that need to get out and might, in some cases, impact chemo clearance, although for some drugs, alkalinization helps with chemo clearance. But it is not universal, and I don't think that you need to alkalinize the majority of patients that come your way. It's not part of my standard practice. Sometimes I give patients furosemide with hydration, and the reason for that is not to pull at them from 2 different directions, but to have high fluid throughput through the kidneys. So they have a lot of fluid going in with normal saline, and the furosemide keeps things moving on the other end to flush out that uric acid. But once again, that's not a universal recommendation. In patients who are high risk, use of rasburicase, which is uric acid oxidase, can help reduce the uric acid levels quickly. But in patients who have G6PD deficiency, you have to be careful. It can cause methemoglobinemia. So in African American patients who are patients of Mediterranean descent, you have to use this agent with caution. I typically follow the tumor lysis labs until about 24 hours after finishing chemotherapy. Usually 3 to 4 days into a regimen, you've probably achieved the bulk of your rapid tumor kill, and you can check the labs less frequently or stop checking the tumor lysis labs. In patients who actually develop tumor lysis syndrome, rasburicase may be indicated if the uric acid is high enough, and they may require dialysis if they go into renal failure. Patients who have tumor lysis syndrome and renal failure have a high mortality risk. So this gentleman who had a large abdominal lymph node bulk for tumor lysis prophylaxis started normal saline IV fluid, and he received twice daily allopurinol for the first 2 or 3 days. So chemotherapy can also cause anemia, and cancer patients in general tend to have anemia. So we'll discuss a little bit about trying to distinguish cancer-related anemia from chemo-related anemia often is difficult. We'll also talk about how this mixed situation is treated. So it can be chemo-induced. It can also be from the neoplasm. It might also be paraneoplastic, and a very common one is anemia of chronic disease, often called anemia due to inflammatory block. So in some patients with cancer and anemia, you may not just write it off to the cancer or getting chemotherapy. It might be appropriate to do an anemia workup to see how much their iron deficit is and whether they might need B6 or B12 or folate repletion. So anemia of chronic disease deserves a little bit of mention because it is a very frequent problem, and anemia of chronic disease usually is associated with patients who have renal disease, but it happens with the same pathophysiology in patients who have cancer or other infectious or inflammatory etiologies. These patients typically have a normocytic anemia and a normochromic anemia, and the reticulocyte count is low. They're not good at making red cells. The hemoglobin is not usually severely low. The ferritin is typically normal, and it might be hard to distinguish from iron deficiency anemia. Its pathogenesis, though, is different from iron deficiency anemia. There is iron there, it's getting trapped and in the wrong places, and it's not going where it needs to go to help make blood. And this is due to a lot of inflammatory pathways that get activated, and their end result is they cause red cells to live shorter, and they cause iron not to be absorbed from the gut, and they cause iron not to get utilized for making red cells. We can cause the anemia with our drugs themselves by killing the cells in the bone marrow and causing oxidative damage. We can also cause hemolysis with some drugs, and some drugs have their own unique syndromes, such as methotrexate or hydrea, which cause a macrocytic but non-megaloblastic anemia. So for some patients, you can tell if they're being compliant with their methotrexate or their hydroxyurea based upon whether they have a high MCV. So if you had a sickle cell patient who's supposed to be taking hydroxyurea and the MCV doesn't go up, you might wonder if they're on medication. Or if they're supposed to be taking one of these medications for another indication, you have a clue as to their compliance. So, who is this? Von Willebrand. Well, wrong country. He's wearing what's called a pith helmet. They were common in the German Empire up until World War I. So this is Otto von Bismarck. And so I use this comment jokingly, but he said that not through speeches and majority decisions, blah, 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 but decisions will be made by iron and blood. And so, he was correct about the treatment of anemia of chronic disease far ahead of his time. So treating anemia of chronic disease and anemia in cancer patients is not a simple matter of giving them oral iron. And that's a mistake I see commonly in medical charts, that someone with cancer-related anemia is getting oral iron. They're not going to absorb it. You're just giving them constipation without any hematologic benefit. So try to find the underlying cause, transfuse them if they're acutely ill, and then try to provide iron supplementation to get a transferrin sat higher than 20% and a ferritin around 800. Now, these are not written in stone, but these are general guidelines that help a patient reduce the number of transfusions they need to get. As I said, iron typically should be given IV unless there's a good reason for iron deficiency, such as bleeding from colon cancer. Erythropoietin-stimulating agents should generally be avoided because they increase mortality risk. So in the early 2000s, it was very common to give darbepoetin and erythropoietin to patients who had cancer-related anemia. until we understood that these agents caused bad outcomes. So they increase the risk of mortality in some patient populations with cancer, particularly those who are not on chemo, and they increase the risk of blood clots in the legs and in the lungs. So erythropoietin and darbepoetin should be used with great caution in oncology patients. To get away from having to use these agents and do a lot of transfusions, you can try to optimize the iron. There are several different iron formulations. Now, iron dextran has gone out of fashion because it has an anaphylaxis risk, and it's not carried by most pharmacies anymore. The popular one these days is ferromoxetol, because it can be given over a 17-second push. And you can get about 1 gram of iron in someone with 2 doses. The middle two were designed primarily for nephrologists who get to see people 3 times a week. And therefore you can, give them their iron piecemeal. But, most patients who have anemia have an iron deficit of at least 1 gram. And so therefore you don't want to have to trickle it in over 8 to 12 doses. And so these work out nicely. We'll talk a little bit about neutropenia, because we also cause that with chemotherapy. Older and more frail patients are more prone to chemotherapy-induced neutropenia, but we can prevent this much of the time with myeloid growth factors. So drugs such as G-CSF, which is called filgrastim, can significantly reduce the neutropenic fever risk. So if your risk of neutropenic fever is thought to be more than 20%, that's a good reason to justify the use of a growth factor. So that's how I decide, is this a chemo regimen where a growth factor is indicated? If the risk of the complication is high enough, it's justified. Otherwise, you're not getting a big benefit. If I can reduce the risk of neutropenic fever by half, I have at least a 10% absolute risk reduction. My number needed to treat is 10. If my risk of neutropenic fever is 5% and I only reduce the risk by 1/2, my number needed to treat is about 40. So that's not very cost effective. And these drugs are not cheap. So that's why you want to target them to be somewhat cost effective. So filgrastim is typically dosed at 5 micrograms per kilogram per day. It comes in 300 or 480 microgram vials. We don't give it before the chemo, because otherwise you're going to trigger the cells to grow, then you're going to kill them. Well, you might hurt good blood cells that way. So we give it 24 to 72 hours after the chemo, and we treat them through where they get low. You don't want to give this when they get low. You're not really helping them at that point. So if someone comes in after chemo with a neutrophil count of 100, and it's a week after their chemo, they're at their nadir. They're probably going to rebound in a couple days. Giving them growth factor at that point is just wasting money and wasting drug and causing side effects. There's a form that's pegylated that has a longer duration of action, less shots for the patient, also more headaches dealing with the insurance company. And I'll skip sargramostim because it's relatively narrowly used. So we define neutropenic fever as a fever over 38.3 or more than 2 measurements over 38 with a neutrophil count less than 500. A neutrophil count that's lower, such as 0 or 100, is worse than 500. The lower the neutrophil count and the longer the duration of neutropenia, the higher the risk of neutropenic fever. Most patients, you won't find a source, but you should try to do a broad evaluation for sources. So that would be culturing, x-ray, urine, blood, evaluate the skin, and check out those lines. And antibiotics that you'll think about using are broad-spectrum antibiotics that have Pseudomonas coverage. So cefepime, Zosyn are good agents. The carbapenems also are good agents, but I try not to burn those up because I want to save them for the truly resistant patients. And if they're penicillin allergic, vancomycin is the way you can go. So I don't want to take too much more time, but for this gentleman who got R-CHOP, for his infection prophylaxis with R-CHOP, which has a reasonably high rate of neutropenic fever, I gave him G-CSF subcutaneous, and he did it the old-fashioned way with self-injection. So we're almost at the end here, and I'm going to just mention a couple things for each item. Cisplatin is nephrotoxic. That's one thing to know about cisplatin. Vincristine from Vinca is neurotoxic, and if you ever go further into this field or you're on an oncology unit, if you're giving intrathecal chemo, make sure that vincristine is not in your bag. Every year, there's about 2 people in the United States who die because of vincristine being given by the wrong route. It happens, and it is a career-ending offense in certain situations. So you don't want to be the person who does this. It still happens, unfortunately. And anthracyclines carry some risk of cardiotoxicity. That's the thing to know about doxorubicin or daunorubicin or idarubicin. And so that's essentially the end of my talk. And if there are any questions, I'll take them briefly. You probably have time for maybe 1 or 2. All right. Well, thank you very much.